Welcome to Robomed, where innovation meets precision and excellence. This is your go-to podcast for cutting-edge conversations in robotic medicine. Stay with us. This is where medicine meets the future.
Hello, everyone.
Oh, hi there.
How are you, Mr. Banerjee?
Oh, I'm fine. I'm very good. Call me Psychop. I think.
Oh, very good. So I am very delighted to bring to you today Mr. Psychop Banerjee. He's a consultant robotic endometriosis surgeon at the Cambridge University Hospital. He's one of the leading figures in the world of endometriosis in the United Kingdom. Of note, he has specialist interest in gynecological ultrasound, but our focus today will be on his role in the management of endometriosis. Without further ado, I will start by saying, could you please give us a little background about yourself and what made you decide to focus your professional work on the field of endometriosis?
Sure. Yeah. No, thank you very much. And thank you to the audience out there for your time. Basically, I'm a consultant obstetrician and gynecologist now, and almost certainly exclusively endometriosis surgeon here at Addenbrooke's in Cambridge, UK. And I was appointed as a consultant in 2006 actually, and I became a pure only endometriosis surgeon in 2017. And essentially, my interest in endometriosis stems from the fact that I am a laparoscopic surgeon and to apply my laparoscopic skills. But interestingly, endometriosis is a massive problem, both here and I'm sure also in Nigeria, with up to 10% of the population being affected by it. And there's a large demand. I also have, interestingly, quite a significant fibroid practice, because the management of endometriosis and fibroids surgically requires similar skill sets. So, and also there's a coexistence of fibroids and endometriosis. In fact, I'm sure a lot of the audience out there will be familiar that when you combine the two, that's the complete nightmare. As I had a case recently where you have a large fibroid uterus obscuring your access into the pelvis, and you're trying to take out this disease as it involves the ureter at the insertion into the bladder. That's about the worst thing you can have, mainly because the fibroids obscure your view. And what do you do there? Because you're doing a myomectomy, and a myomectomy compromising patient, strength to then go on to do the more complex part of the operation, the endometriosis part. But that's my interest, and I have sat on the British Council of Gynecological Endoscopy and the Royal College of Obstetricians and Gynecologists, and also I've got recently a book out. I'm editor. I've invited my friends across Europe to write their specific chapters on areas they're very interested in about endometriosis management. That is, in a short, my interest, and I hope I can interest you in the next short period of time. I'm very much a minimal access surgeon, not because I wish patient recovery, it's because I believe that endometriosis surgery is microdissection, and microdissection is best achieved by the vision that's afforded to you by minimal access surgery and laparoscopic surgery. And then I've now moved to robotics, because robotics is an extension of straight stick laparoscopic surgery, and it helps me, and things that help me are obviously going to be very good, and I need all the help I can get, I have to admit.
Absolutely.
So, help me.
Absolutely. I mean, yeah, and that's brilliant. You've given us a very good elaboration, highlighting the complex nature of the surgery for endometriosis, and obviously the fact that we do know with robotic surgery, the visualization is way better than what you get with conventional laparoscopy. So I'm sure that will be very useful to your practice as well. Now, having mentioned some of the benefits of robotic surgery, what other reasons were behind why you decided to transition most of your case to the robotic approach? I know you've highlighted some of that. I'm sure other issues in regards to pain management and shorter hospital stay, if you could potentially give us more elaboration on that as well.
Sure. I mean, particularly I have to say my fibroid and non-endometriosis practice, improvement in length of stay is significant, and improvement in post-op pain management is very significant. For endometriosis, it's slightly more trickier because they come with pre-existing pain conditions, and the management is quite difficult. There are advantages in recovery, of course. So if you do a hysterectomy for menorrhagia, patients recover much quicker than a hysterectomy for endometriosis because they come with background pain, and that's difficult to manage. Their background set of pain is much higher. But yes, there is an improvement. But the greatest one has got to be access and vision. So I talk about my patient the other day with a fibroid that I had to do by laparotomy because of her enlarged fibroids. A myomectomy for very large fibroids ended up being a midline laparotomy above the midline, above the umbilicus, just for the myomectomy alone. But I really wanted to close the patient up and dock the robot and do the endometriosis, actually, because the vision afforded is absolutely superb. Laparoscopic surgery, however, is getting better and better. So we have now 4K 3D stacks, which almost compared to robotics, but robotics has the advantage of for all you guys out there who do robotics, you can say your platform is incredibly stable, and that stable platform is really an advantage. And for those of you who do laparoscopic surgery out there, the vision is great. You can't knock it, especially with if you're using these newer cameras, and there's lots of evidence out there that shows that diagnostics of endometriosis lesions are far improved by using 3D instead of 2D, by using 4K instead of standard definition. But the thing they don't show is a stable platform, and I never realized it until I converted to robotics, and then occasionally have to go back to laparoscopy. I suddenly feel quite seasick laparoscopically, despite having done it for 20 odd years, because I don't have that stable platform, and my brain finds it difficult to accommodate. And I haven't realized robotically how much better it is until I've tried to revert back. So have you found the same thing, Ahmed, when you in your practice?
Absolutely.
Platform.
Yeah, I mean, you've highlighted that. You remember the issues with hand tremors with laparoscopy.
Yeah.
So you see that is completely removed with robotic surgery. So that's a massive advantage. So you have a very steady field, and that gives you the opportunity to focus on the surgical side. Yeah.
And strangely, I never realized that until I had to go back and do laparoscopy. And then I was going, God, how did I ever manage doing this laparoscopically?
Yeah. And then if you think about, especially in gynecology, we do operate in the pelvis, which is a very narrow space.
Yeah.
So again, with robotics, because of the scaling opportunity, so regardless of the nature of how large your hand movement is, the robot is able to scale it down, and all of that obviously will add to safety. Yeah.
Absolutely. And the articulation of the hand units, especially as I've got 3 hands robotically compared to 2, because I've got 3 arm control, really allows me to work in tight spaces.
Yeah, so it does.
Working down on the intersacral ligaments in the corner of the pouch Douglas is really much easier using articulation, especially when you go down to sacral nerve roots and things like that.
Absolutely. That's correct. Now, having clearly stated some of the obvious benefits of robotic surgery in endometriosis, now for doctors, for instance, who are thinking about starting a robotic program for endometriosis, how do you think it's going to be possible for them to do that, especially in a resource-constrained setting? What will be advised in that regard?
Well, I mean, I think the most important thing is you need access and exposure. So you need patients who require the treatment, and something that's got a 10% prevalence rate in the UK, certainly, and probably in Nigeria, you have the demand. Then you need the access to robotics, and that's very important. Without the access and exposure, you're stuck. And then with the exposure, you get the training. And, working for people who have expertise, you can jump on their learning curve. So my current fellow will surpass me and do much better than me, because she's currently working on my learning curve, and then going to surpass my learning curve as she lives much longer than me. And that is going to be the way. That's got to be the way forwards, doesn't it? Really, I think is the only way. If you can't go and get a fellowship, then you can buddy up with people who are good in laparoscopic surgery. You may be good in endometriosis, and your buddy. So in my case, my colleague is a urogynecologist, has a lot of experience on the robot system I used. I've got a lot of experience in endometriosis, so I buddied up with him, and he taught me the robot, and I applied it to endometriosis surgery. And actually, the jump from laparoscopic surgery to robotics, it requires dedication, because the hand movements are very different. But with the dedication, the actual surgery, the application of surgery is no different. And the microdissection is no different, other than, strangely, it's much easier. Endometriosis surgery robotically is incredibly easier done robotically than laparoscopic. I'm not sure I find hysterectomies that much easier. It's better and it has the patient advantage of recovery, but endometriosis surgery is so much easier robotically, because the ability to microdissect is just phenomenal in comparison. And also you can see structures. I can say ashamedly, I can say that I used to operate on days of CRT monitors, and hypogastric nerves were a fictitious thing that you would talk about. And now even the most junior SHO, junior doctor in my theatres, with our HD stacks and our robotic stacks, can see the hypogastric nerve, just a diagnostic procedure. Seeing means you can avoid damaging.
I mean, what you're saying, it's quite good, especially for endometriosis surgery, like you rightly alluded to, given the technical difficulties and the complexity of the surgery, with significant dense adhesions, which usually are often the case. Now we're going to go on to talk about the specific role of robotic surgery in the management of endometriosis. But what I would like you to do now is to give us the emphasis and indication why you would want to then say, okay, for this case, I think I would rather go the robotic approach as opposed to going the other options of treatment. And if possible, just add a note on what the limitations are.
So, I think the limitations of The limitations of robotics are access and cost, and also you have to lock on the robot, and to lock on the robot takes time. It's just a obvious fact that if you don't have to set up a robot, you save the setup time, and if you have to set up a robot, you add a setup time. The more efficient you are in setting up the robot, the better it is. And setting up the whole of operating theatres is a bit like a Formula One pit stop. And the more everyone is working well in that Formula One pit stop, the quicker the actual process is, and the less you have to do as a surgeon, the less distracted you are, and the more you are focused into surgery. And the more technical surgery gets, the more distracting it gets. Laparoscopic surgery is more technical than open surgery for everybody else in theatres, and robotics even more so in setting it up. So that's the downside of robotics. But when would I apply it in endometriosis surgery? Do you know, I'd apply it to all endometriosis surgery, because it just makes it easier. The more complex the surgery, the more help I need to making it easier. But, why not make even the most simplest operations just that bit easier? And the ability to go in and micro dissect something, which is what endometriosis surgery is. If you're an excisional surgeon and doing a peritonectomy and then diving deep down, say, those parametrial nodules, you can really see structures. And if you can see structures, you can then avoid damaging them. And if you see the structures much more easily, you are less likely to damage them. So I think that's a big advantage. I haven't yet. A theoretical advantage, I think, is that if you run into a bleed emergency, you need to emergency undock the robot to move it out of the way to convert to laparotomy. I can see that as a real issue. And touch wood, I haven't come across that risk, but it's something, if you take onto robotics, you must prepare for that emergency DDoC. Just as if you do laparoscopic surgery, you must be prepared for that 2 in 1,000 risk of major bowel blood vessel injury that needs an emergency immediate laparotomy to control your aortic bleed.
Absolutely.
And that I see as a downside of robotics. But I think one of the other downsides of robotics is its dependence on it. So I've found that I can do everything laparoscopically, and more recently, if I don't have access to the robot, particularly for more complex rectovaginal disease, I say, I'm sorry, I'm not going to, particularly actually for the parametrial neural disease, more and more I turn around and say, I'm not going to take it on without a robot. And I've cancelled patients on the day because the robot's not been available, mainly because it's not been feeling well. Something that's more technically complicated also requires engineers and background setting up. And these things are delicate things. I'm lucky I use a Cambridge medical robot. I'm in Cambridge, so therefore my backup is a little bit better.
It's easier. Yeah,
but
absolutely.
if I have an arm failure, then the Cambridge medical robot out there for you, they use independent arms. So if one arm fails, I won't convert to a 2-arm operation. I will then say, it's elective surgery. I'll bring the patient back when I have 3 arms. That's the thing.
Yeah.
And you don't have that in laparoscopy.
Yeah. And then what will you say again for career longevity using the robot here for your complex?
Well, I do have my rotator cuff injury to demonstrate my though robotics, interestingly, has its own issues on the Da Vinci system. There are issues with neck strain and neck positioning. In CMR, I'm sure sitting with these funny joy controllers must give you some kind of thumb injuries. But I suspect there are advantages. Yes, absolutely, the longevity. The other thing I would say to a budding surgeon out there, whether laparoscopic or robotic, is exercise and Pilates, because building up core strength on those particular individual muscles is actually quite important. Something we don't actually take into account, but one of my mentors, who's a surgeon in Bend in Oregon, was for many years ago, David Redwine, a very famous endometriosis surgeon. He used to work out in the gym to build up his core strength so he could work on his laparoscopic, though he didn't use to use video cameras, he used to use eyes only down the scope, and that was many years ago though. So exercise out there would help. But robots, absolutely, you're sitting there, you're comfortable, and by sitting there being comfortable, you are actually much easier to operate. However, a downside of robotics is because you're not on patient side, you're more remote, you depend on the patients on the bedside much more. And one of the things I would say for anyone setting up a robotic program is to have a good, at least in UK practice, is to have a good nurse, surgical care practitioner, SCP, because juniors, trainees aren't interested in bedside. They want to be on the robot. So they never look at what's happening on the bedside. They drift to the robot. But you need actually good bedside working to change that suction irrigation, change the arms, move the positions. And these are things you naturally do when you do laparoscopic surgery, that with robotics, because you're away from the patient, you don't do. So I would say get a good STP.
Yeah, that's good. Yeah, I mean, thank you very much. And now we're going to move on to the role of MDT, multidisciplinary team work. And I want you to highlight how that enhances your decision making prior to surgery.
MDTs are interesting. MDTs are very topical and must be good because it's an MDT. And to some level, I have some skepticism of MDTs. But, when I really started to truly embrace the MDT, it suddenly taught me actually how much better, I have to say, improves patient care. I used to do everything myself. I used to do the ultrasound scans myself. I used to work up the patient myself. I used to do a lot of the colorectal surgery myself. I used to do my own appendectomies. I used to do my own disc resections. I didn't do segmental bowel resections by myself, but I involved the colorectal surgeons near to the end of the procedure in the actual stapling device. And now in my current practice in Cambridge, the colorectal surgeons are involved in the decision making. They see the patients, they understand. We agree with them in meetings whether to operate or not. And actually, they take a much larger part in the surgery. And, actually, for the better, because they understand colorectal diseases much better than I understand colorectal diseases. And they bring a much different focus to the patient's management, which actually I have found really refreshing and really helpful. And in doing so, the three I work with who are very much interested in endometriosis surgery have embraced endometriosis and endometriosis colorectal disease really well. And the net result is it's really nice to have a friend you can bat off with for decision making who actually you can it gives you that security. I had that the other day with a patient who we were going to do a segmental bowel excision for, but actually looking at the overall picture, this lady has a raised BMI and quite significant sleep apnea problems. Do we really want to envisage on a prolonged long operation when actually, do you know what? She may be quite responsive relatively to medical treatment. So we combined it with a more abbreviated, so we did a rectal shave rather than a full thickness and segmental, because on MRI we felt that there was a long segment involvement. We managed to shave the disease off to looking normal, but we know when we do a segment that actually there's underlying disease within the mucosa. MRI in our hands is really quite accurate. So it's incomplete disease excision in one way, but actually on the other side of it, this lady is perimenopausal, and doing a segmental resection will add another couple of hours onto her surgery, and we're already having problems with Trendelenburg, and therefore actually to abbreviate her surgery is not taking a more conservative approach, is actually taking a more sensible approach. And that was actually interesting, something that the colorectal surgeons felt. And they did that on a breakdown of her colorectal symptoms. So they focused very much on her colorectal side of things, and they looked at her colorectal symptomatology and felt that the colorectal symptomatology was much more non-endometriosis specific. To them, it's not just ischemia, it's bowel function as well, and its ability to recover.
And also, I think the radiologists too will usually go through the MRI report and help you in defining the extent of disease, so that you do know what to expect when you go to surgery.
Yes, very much so. And also, so I would say, and I've got this in my book as well, that the advantages of particularly of MRI, cross-sectional tomography, is easier to relay information at MDTs. And in fact, our radiologists, as Ahmed will know, having been in Cambridge before, can actually operate cross-sectionally with MRI. They can take me through an entire operational procedure layer by layer and tell me what I will find if I demand it, which I do in very rare circumstances. But I would also say to the budding gynecologist out there that it's worth doing your own imaging too, looking at your own MRIs, and MDTs will teach you that. So my radiologists have taught me MRI for endometriosis over the years, but also doing your own ultrasound imaging, because there's first-hand acquisition of information, tissue planes, movement of tissue planes, access into various compartments. You can't beat it with ultrasound, and actually by doing your own ultrasounds, that helps you in your surgery. So I would, any budding robotic surgeon out there, if they have a background in transvaginal and gynecological ultrasound, I would say the two go hand in hand, and you should apply that. Ultrasound and laparoscopic surgery are very much the same thing, or robotic surgery are very much the same thing.
Exactly, especially say in developing countries. I know cost-wise, Doing an ultrasound is by far cheaper than requesting an MRI for our patients. So it
Yeah,
fits perfectly well, especially for us who are aspiring to practice in developing countries.
and I would say to you that if you look at the literature out there, in the best hands, MRI and ultrasound scan are actually comparable in both sensitivity and specificity. So
Wow, that's
one isn't superior to the other. Now, I have to say, maybe in a resource poor environment, doing your own ultrasound, you can achieve as good a result as you probably could do with MRI, and you can operate. And this was my practice as a consultant initially. But when I switched to Cambridge, I have to say one of the downsides of MRI, of ultrasound scanning in clinic, is it's time consuming. And my resource that I'm limited in is time, purely time, and therefore my ultrasound practice has dwindled to my MRI practice because I can involve somebody else in literally doing the image acquisition. Plus, it aids in communication with the MDT. But I still practice my own ultrasounds in difficult cases in particular because it gives me that added information that prepares me for knowing. So I actually, a good question in that, Ahmed, is diagnostic laparoscopy and the role of diagnostic laparoscopy. I think diagnostic laparoscopy to set your operation and your robotic surgery is really useful. It gives you really good information. And for those out there who swear by it, I absolutely go with them. I have never done a diagnostic laparoscopy since 2004. And the reason being, I have replaced it with ultrasound scanning, MRI, and history. And if I was a patient, I'd rather have an ultrasound and an MRI and take a history than I would have a diagnostic laparoscopy. But if people come with a diagnostic laparoscopy, I don't ignore that information. I take it, but I don't need it. So our patients don't have diagnostic workup; they have imaging workup. And robotically, that's helpful in terms of working out theatre times and how long these things will take me. And who needs to be present at the surgery? Do I need reconstructive urology? Do I need colorectal surgery? Do I need a standard urologist? Am I going to do cystoscopy with ICG before I do my robotics? These sorts of things.
Yeah, absolutely. I mean, thank you very much so far. You've highlighted quite well, actually, the obvious benefits of robotic surgery and also the role of ultrasound in the management of endometriosis. Now, I want us to switch gear a little bit and focus on our patient. Yes. So now, if for women generally out there who suffer from pelvic pain and are seeking specialized care, what advice do you have for them, generally speaking?
Well,
in terms of how to it,
there are varied opinions on this, and a lot of people say they should be seen by specialist centres. I would say, look, 10% of the population suffer from pelvic pain, and 10% of the population can't go and be seen by one specialist, because that doesn't make that person special and they will collapse. And the majority of endometriosis management isn't surgical, it's actually medical and conservative. And what it needs is primary physicians out there who see the patients to recognize those patients and find the red flag symptoms that tell them that they need to then be referred to specialists like yourself and myself. And, so as you know, you ask because my background research interest was just that.
Absolutely.
And if you have a departmental ultrasound scan, a basic level ultrasound that says this patient's got endometrioma, in the background of pains that are not just dysmenorrhea but additional pains, and in particular dysesthesia, this is indications for referral to a specialist centre, as is the presence of a rectovaginal nodule, which you can pick up on bimanual examination, or a good bimanual examination in the stuck pelvis. These are indications, again, to a specialist centre. And I would argue, in a resource poor centre, those are indications for just doing a renal tract scan, which you can also learn to do yourself, just to look at the kidneys to hydronephrosis. So if you scan someone or you examine someone and they have a stuck pelvis, or they have a rectovaginal nodule, or they got endometriosis, just have a look at the kidney poles to make sure they don't have hydronephrosis. Because if they've got hydronephrosis, then you absolutely must send this patient to a specialist centre without a doubt. That's one of the few indications, I think, where surgery outstrips medical treatment. But other than that, you can manage medically.
Yeah. Thank you very much. Do you have any advice for upcoming or even aspiring robotic surgeons?
In terms of
general advice, how to go about it for aspiring surgeons?
I actually changed that a little. I would say, do I have any advice for gynecological surgeons? My advice for gynecological surgeons is robotics is the future. Do you know?
Brilliant.
I robotics and vaginal surgery. I'm also involved in VNOTES, transvaginal laparoscopic surgery, and the Da Vinci system has its single port system that's now moving down that direction. I know that vaginal surgery, but I don't do very much vaginal surgery. Luckily, I specialize. I'm out in the world of endometriosis. But for those who do prolapse surgery and incontinence surgery, vaginal surgery, absolutely. But if you focus yourself on endometriosis surgery, then minimal access surgery is absolutely the way forward, of which robotic surgery is quintessentially the way forward. And what you really want to do is you want to get exposure to it, and the way you get exposure to it is you want to find someone who does it and you want to go and work with them. And some people, I take my hat off, some of the people who come and work with me come from all around the world, and that level of dedication, I am really impressed. You know, to leave your home country, you know, I've had people from Africa, from Nigeria, from Holland, from France, from Korea, as well as, of course, from my home country of India. If to give up your sacrifice your home life to come across, to do a fellowship, to expose yourself, is really a impressive commitment. But you deserve to succeed in every way, I would say. And sometimes that's good, and then you have the added advantage compared to me. I'm lucky. I work in an area that it's more the norm, but you then spread the word quite rightly, because patients are patients across the world. Women are the same. We all are built in the same way, and we have the same ailments. And to then apply that in that setting and spread the word is, really impressive. So for any of those out there in Africa, my advice is find people who can do it. You may find them at home, and it's definitely a English Anglo arrogance to think you can't, because you absolutely can. And there are centres being set up. I believe you are setting one up yourself. Yeah. And you are a colleague to come and work for, I would argue. But otherwise, across the world, US, wherever you get access, really, because that's important. But you need to be able to apply the skill back at home. So when you come back home, you need to be able to have the resources for you to be able to do it. And that's a whole new different story. And I think, Ahmed, you'll be better to advise them than me. I need to interview you as the next meeting to ask, how do you set up a service and how do you get that resources and training? Yes. I'm lucky it was given to me.
Absolutely. Yeah, I mean, I'm glad you've said it. Robotic surgery is the future of gynecological surgery.
Yeah, absolutely, without a doubt.
Very good. And so, on a final note, do you have any general thoughts or comments? Just so you know, we're doing this as part of the March Endometriosis Action Month. So, do you have any comments to say in regards to that or anything? Take it away.
I think your work out there is valuable and required, and dedicating yourself to it is really, really important. There's very little I have to say. It's our patients who say it all. And in fact, a lot of you will be familiar with Oscars for films, but the British equivalent to the Oscars is the BAFTAs. And this year's BAFTA winning short film was won by a film that was titled "This Is Endometriosis."
Oh, good to know.
It's a really good film, and it's a film I would entice you to Google up and watch, because it tells you what endometriosis is in a very good film. You watch that film is my patients. If you meet someone like that, that's the person who'll do well from surgery and doesn't need 11 years of going to see their general practitioner or primary care physician, 9 to 11 times a year over that period of time. You can work that problem. That person needs to go to the specialist center and see you, the robotic surgeon, because it's your skills that they're looking for in excisional treatment. And then you need to also have a team with you, because it's not just surgery. It's a lot more involved in it, in terms of patient counseling, in terms of pain management, in terms of medical management. So that's the multidisciplinary team. I'm lucky. I have a pain management team with me. I have now a pain gynecologist with me, pain physiotherapists, pain psychologists, primary care physicians who are interested in it. You need to build up the team. As a surgeon, you're one part of the team, and as a surgeon, you need the team so that they triage the patients for you, so that you're there to operate on the correct patients. As surgeons, we're athletes. We want to operate a lot. We want to compete at big events, and the more events we compete at, the more sprinters need to sprint, and they need to do lots and lots of sprinting. And as surgeons, that's what you need. So you need other people to triage those patients for you, so that you are operating on the correct patients as much as possible.
Wow.
That's a lot I've said as a summary. So really, I should hand over.
Yes, thank you very much. Thank you very much. It's been quite a useful session. And I think on this note, I will say a very big thank you once again for doing this. And we hope to host you again.
And best of luck.
Yeah, absolutely. Thank you very much. Thank you. See you.
All right, then. Nice talking to you. Bye-bye.
Bye. Bye. Go.